Our grand round speaker this morning needs no introduction. Dr. Greenhalgh, former president of the American Burn Association and really a distinguished leader in that field and a distinguished member of our department, is going to talk to us about sepsis. Hard to imagine that there's something new in sepsis. It's been around a long time, but it's a problem we have not yet solved. So thanks, Dave.
Thank you very much. I have nothing to disclose, so I have to have a picture of the medical center. So what I want to do today is give you new concepts about response injury. There are some new ideas and sepsis. A little bit of basic science, but not anything from my lab this time. But there are new definitions, new treatment standards that are out there, and so this is going to be good for the new residents, maybe the old residents, maybe the old docs. And then talk a little bit about burns. Burns is a special problem. So if you think about it, after trauma, there's three ways basically you die. You lose your brain, you bleed to death, and those that survive that go on, develop sepsis, multiple organ dysfunction syndrome, and that's what most of our ICUs are full of. So this is a great paper by Medsadov who talks about the philosophy of inflammation, and inflammation being an adaptive response for restoring homeostasis in response to some form of stress, and it can be very simple. Basically, it wants to either get rid of it, like drain an abscess, or sequester it, keep it walled off, and allow the host to adapt to a new situation, and then restore functionality and homeostasis as much as possible. And it turns out our body is just full of resident macrophages who are basically the sentinels. Their job is to look for any perturbation in the tissues, and if it happens, then they go ahead and send signals to call for help. If there's major stress, it calls for additional help, and then it can even lead to, if can't deal with it, apoptosis in some of the local cells. And you know, there's severe insults, trauma with the burns being the ultimate insult that you can have. And sepsis is a really profound area, but it could be small, an abscess, or just a foreign body that it walls off, hyperglycemia. And if it's very mild, the cells take care of it. And you could succeed, the infection goes away, or you can heal the wound and get back to normal. Or a lot of times it's a stalemate. I can't deal with it altogether, so we're going to live with this foreign body the rest of our lives. We'll have diabetes and deal with these problems. Have a cancer, die with it. So in very simple terms, we have two kinds of defense systems. The innate immune system, which is involved in all cells. It's basically a receptor that detects a foreign body, leads to a response. And then the adaptive immune response, which is basically only in advanced vertebrates. It doesn't exist in beetles or insects or other different types of animals. And you can divide the response to injury into four factors. Okay, there's inducers. That's a signal that starts the response, and that's classically the PAMPs, or pathogen-associated molecular patterns, or DAMPs, which are the damage-associated molecular patterns, and the classic PAMP is LPS. Mitochondria are classically the damage-associated molecular pattern. Then we have receptors. We evolved receptors for all these, and those lead to response, such as the TLR4, but there's hundreds of others. That leads to mediators, cytokines that produce response, and then the effector cells are the cells that try to act on that process. And this is a simplified version. We could show you it's really, really complicated. I won't get into that too much. But it's interesting. So just like any injury, there's a huge capillary leak. And that's due to mediators. And the endothelial cells are the cells that regulate this process. And how much you leak is proportional to injury. Again, for burns, we're the positive control. My record for 24 hours is only 100 liters, so it could be a huge amount of fluids. And a little basic science that the junctions that hold the endothelial cells are three things: the tight junction, the gap junction. The gap junction is more for communication, and the one that really regulates the process, the adherence junction. And turns out the little molecules actually swap in the middle, and they can unswap and allow the cells to separate a little bit. And it turns out that they are hooked up to these little motors, actin and myosin, and they can show, and those can actually respond and pull the cells apart. And in a resting state, nothing happens, but when you have binding to a receptor, the GPCR receptor, and it can be many different factors, the motor pulls the cells apart, leads to that increased permeability. All right, and then when you have excessive inflammation, those cells spill into systemic circulation. You get a huge leukocyte response, and then we get sepsis. We'll talk a little about that. It's an unbalanced response to infection. If it's too extensive, like an 80% burn, the cytokines spill into systemic circulation to go to the brain. The hypothalamus detects the damage, and it goes to the pituitary, releases catecholamines and corticosteroids. You get preferential wasting of skeletal muscle. So that's the process we get that leads to a huge response. So more clinical now. Sepsis is a big cause of death we talked about. There's been huge campaigns to improve outcomes, and the Surviving Sepsis Campaign is one of those, and we'll talk about that. And the idea is that the earlier you treat the sepsis, your better chance of survival. So they've created bundles that you're supposed to do and do them early in order to improve outcomes. So there's a high incidence, 437 per 100,000. So over 30 million cases per year, and that's 5.3 million deaths per year. In the high-income countries, you're doing a little bit better, 20 to 25% survival. Low-income countries, sepsis is pretty high mortality rate. And the other thing is that it's almost a 30% readmission rate if you have sepsis, so it's a big problem. In the long term, if you develop sepsis in the hospital, you're at higher risk of dying within 5 years. You also have cognitive and physical impairments very often, and I won't get into the studies, but there have been hundreds and hundreds of millions of dollars spent on blocking one signal in the sepsis pathways, whether you antibodies against LPS, against IL-1, against TNF, whatever. None of them worked. We did have activated protein C for a little while, which had a statistically significant difference, 28% survival versus 24%. It's off the market now because of bleeding problems, so there is no magic bullet. So many things are involved. As I said, inflammation initiated by the PAMPs and DAMPs. Complements activated, coagulation's involved, the endothelial cells are activated, mainly tissue factors a main driver, endothelial cell dysfunction occurs, platelets are activated, neutrophils create these traps, extracellular traps that basically catch the bacteria inside the blood vessels, increasing thrombosis. B cells are involved. And I won't get too much into it, but there's feeling of two things. There's a pro-inflammatory response, and then there's an immunosuppression that occurs, apoptosis, and that's going on in huge amounts. So it turns out, if you really want to get fancy, the vagal nerve's involved in the process. If you stimulate the vagal nerve, you inhibit the pro-inflammatory response. So it's a sympathetic, parasympathetic activity. They talk about the metabolism gets altered, something we call the Warburg effect, shift from oxidative phosphorylation to glycolysis. You get succinate accumulation, which activates other factors. The microbiome may be involved, what kind of bacteria you have in you. And then Fred Moore in Florida has talked about the persistent inflammatory immunosuppression and catabolism syndrome, PICS. So you have a chronic immunosuppression and breakdown syndrome. So here's again a cartoon showing how complicated it is. But it's interesting that you have links between the pro-inflammatory signaling, but also insulin, glucose. There's interaction with inside the metabolism of the mitochondria. If the proteins don't get folded right, there's other signals, so it's a very complex process. There's your organ damage, and you can't clear the infection. So the classic teaching is this. It's basically you have a pro-inflammatory response, and that's followed by a basically compensatory anti-inflammatory response. So you're pro-inflammatory and then compensatory anti-inflammatory. And then if you have a second infection that occurs again and it keeps going, and if you can't get through that, you die. Well, that's been challenged now, and if you go to what's called the GLUE grant, where they looked at trauma patients, burn patients, sepsis patients, they looked at their gene expression, what happened right after a major trauma. And this is what they look like, the genes. And basically, you know, it's red's activated, blues turned down. And this is kind of what you could see, that this is what the normal situation is. And you have a major injury, major sepsis. Boom, these guys turn off to the opposite signaling. And at the same time, you get a change in other genes. So it's a complete change of what's being expressed in the gene, so that you go from a inflammatory to anti-inflammatory response. And so kind of the genomic response is very fast, and you have a long effect with burns. But if you compare what happens with trauma versus burns, very similar activation and downregulation. LPS is also pretty similar, so that there's a switch in what becomes pro-inflammatory, what becomes inhibitory. So the kind of their new scheme then is that major injury, major burn, major sepsis, you get a turn on of both pro-inflammatory and anti-inflammatory genes that occur instead of the one then followed by the other. And if you have a complicated outcome, you can either be a persistent pro-inflammatory response or a persistent anti-inflammatory response. And then people talk about different pathways. Do you end up inhibitory or pro-inflammatory, so you can have that wasting away? So that's kind of the schema, what's going on. We have definitions. It used to be an unbalanced response, reorganization of the immune system. It's unbalanced, so you don't get back to normal. So the new things that have occurred, and we had old definitions, but they had a huge task force, met in 2015, and published in 2016, called the Sepsis 3 definitions, which you guys should know. There used to be sepsis, which is kind of that inflammatory response, and they call it severe sepsis, which used to be SIRS mixed with organ failure. That's gotten rid of. So it's now all we have now is sepsis and septic shock, which is shock related to sepsis. So here's some definitions that came out in JAMA just within a year. Sepsis, a life-threatening organ dysfunction caused by dysregulated host response to infection. Okay. And septic shock is a subset of sepsis in which underlying circulatory cellular metabolic abnormalities are profound enough to increase mortality. Those are kind of squishy, wishy-washy definitions. So how do you define them clinically? So what do you do for sepsis? It's suspected or documented infection, so you have to have an infection, with an increase in greater than 2 SOFA points. SOFA basically is a system of looking at organ failure. And septic shock, this takes sepsis and the need for vasopressor therapy to keep your mean arterial pressure greater than 65, and or a lactate that's greater than 2 millimoles despite adequate fluid resuscitation. And they said, again, this is 40% mortality once you get in septic shock nowadays. So that's one thing that happened, and there's been this campaign, Surviving Sepsis Campaign, which all residents should get a copy of it. There's been 3 publications. The most recent came out in January of this year, 2017. And the concept is this: early treatment bundles should improve survival. And there's been pretty good evidence to show that if you start therapy early, you have a better outcome. If you delay it, mortality goes up. So you need to look for sepsis. If it happens, you need to make a change, do it quickly. So our EMR has sepsis alert or SIRS alert. SIRS is what we call Systemic Inflammatory Response Syndrome. And what the definition is that either hypothermia less than 36 or greater than 38 degrees, heart rate greater than 90, respiratory rate greater than 20, and a white count, look at your white count, less than 4,000 or greater than 12,000. That is a trigger to initiate antibiotics. So what we've done here is that you'll get that alert, it automatically starts the process, okay? So what the standard is now, that what you should do within 3 hours of an alert, measure lactate. Lactate's become the big thing now for sepsis 3 definitions. Obtain blood cultures right away prior to antibiotics, because obviously if you start them before you get blood cultures, you may not find out what's causing the problem. And give broad spectrum antibiotics. And standard is then administer 30 milliliters per kilogram crystalloid for hypotension, or if the lactate is greater than 4. Within 6 hours, you should start vasopressors for hypotension unresponsive to initial resuscitation. Again, the target is greater than 65 MAP. If it persists or initial lactate is higher, 4. Reassess volume, look at tissue perfusion, check the patient. And they also say you can check the CVP. CVP is not very accurate. You can look at saturation of your CVP oxygen. Look at ultrasound, just look at volume status. They have a new thing now, which we didn't have a name for when I was a resident. It's called passive leg raise. We used to call that Trendelenburg. So if you lift the legs up, it's a brand new thing, you know. So lift the legs up, wow, and they get better. Oh, you're dry, you probably give more fluids. Or you can give a fluid challenge, okay. We just didn't have a name for it. If they lift the legs up and they start foaming at the mouth, you're probably in failure. So, okay. And remeasure the lactate. All right, so I'm going to go over what the Surviving Sepsis Campaign says in more detail, okay? So you guys should know this. Sepsis, septic shock emergencies. Start treatment very quickly. 30 milliliters per kilogram IV crystalloid within 3 hours. Used to be the bolus 20 milliliters per kilogram, now it's 30, okay? Basically, you assess the patient. Maybe you need more fluids. Look at other parameters that might be helpful, because the clinical exam may not help you. They like dynamic over static variables. Again, the MAP of 65 is the goal. Aim to lower the lactate levels. Well, they say you should have a performance improvement, and we're doing that with the SIRS alert, okay? Make a diagnosis, so get cultures prior to antibiotics. All right, so start antibiotics within 1 hour of diagnosis. And you want to start empiric antibiotics to cover what's likely, okay? So you should know what's likely. In a burn patient, it's something resistant to everything, so we have very broad coverage. Once they're identified, though, you should narrow the antibiotics and cover what you find, okay? They recommend against prolonged prophylaxis, for instance, in pancreatitis or burns. I'm glad they've listened to us. And then use pharmacokinetic, pharmacodynamic principles. Very often you should start at least 2 classes of antibiotics. We always start like something to cover gram-positive, gram-negatives. Do not use combination therapy for other serious things. Not sure exactly what they mean by that. Talk about neutropenic, don't use combinations. De-escalate if you get better, okay? So you don't want to have prolonged antibiotics because you select out resistance. And treatment for 7 to 10 days is adequate for most infections causing sepsis or septic shock. Longer course is recommended, however, for undrainable foci, Staph aureus, some fungi, viruses, if you have immune deficiencies. Shorter courses are appropriate for patients with rapid resolution. Daily assessment, you should look what can we cut back. They do recommend maybe you can use procalcitonin, something we haven't used, to shorten therapy or discontinue antibiotics to get down to a level you might be able to stop. This is a new thing for some, but source control makes sense. Drain the abscess, cut off the infected burn, whatever. So that's important. Change your lines. Line sepsis is a common cause, so change your devices. So when you need a vasopressor, the drug of choice is norepinephrine. You can add vasopressin or epinephrine after that. Dopamine, maybe. Dopamine's fallen out of favor. Dopamine for renal protection's gone. Doputamine's a good drug of choice if you need basically inotropic support. And if you're going to use them, put in an A-line. Keep challenging the patient as long as it's stable. Crystalloids are the choice fluid. But add albumin when they require large volumes, like my patients, when they get albumins less than 1, we do ask them. Don't use starches. Many good studies now show that starches increase renal failure. Don't use them. Don't use gelatins. The steroid thing's still there. Don't use steroids unless nothing works. Then use steroids. That still hasn't changed. There's been good studies that show that empiric treatment with steroids don't work, but we all use them when nothing else works. That's still the recommendation. Maybe someday they'll figure it out. The dose, 200 milligrams per day. Blood products. Dr. Palmieri has done a study for burns. It's been shown for others. You don't need to transfuse until the hemoglobin's less than 7, except maybe with myocardial ischemia, severe hypoxemia, or if you're bleeding to death like the trauma guys. Erythropoietin, don't use it. Don't use fresh frozen plasma unless you're bleeding. Don't transfuse platelets unless you're less than 10,000 or less than 20,000 when they're at risk for bleeding. If you have active bleeding, get it up to greater than 50,000, or if you can go to the OR. Don't use immunoglobulins. Blood purification, there are studies to look at whether plasma freeze patients, does it have help? There's no good evidence yet. Don't use anticoagulants. And ventilations, this is practice for ventilations. 6 milliliters per kilogram tidal volume. This is for ARDS and related to sepsis. Try to limit the goal to 30 centimeters water. Use high PEEP instead of low PEEP, so don't have high pressures, low PEEP. Use recruitment maneuvers. Prone positioning may help. Don't use high frequency, no evidence for it. They don't have any recommendations for non-invasive CPAP. The idea now is if you're having troubles, neuromuscular blockade is okay for 48 hours. Studies show that might improve things if the patient's struggling to breathe. Try to be conservative with fluids if you need to. Do not use beta-2 agonists if no bronchospasm. If you're going to do it, don't use a PA catheter. PA catheters kill people just like endotracheal tubes kill people. The incidence of death with people with IV is higher than those without, too, so IVs kill people. But PA catheters, they don't have to use. Again, lower tidal volumes, they said, again, keep the head elevated. Spontaneous breathing trials are good. These are stuff you'll use in the ICU. And weaning protocols can help. Minimize sedation if you can. Glucose control now, used to be we had a target of 110. Now they're saying greater than 180. You should start. If you do, glucose every 1 to 2 hours. Be careful of point-of-care glucoses because they can be inaccurate. Use arterial blood over capillary blood. They still say that it doesn't matter whether you use continuous or intermittent renal replacement therapy. However, CRRT is easier if you're unstable. Don't treat just the creatinine and the BUN, but use other indications for treating for renal replacement therapy. And this is now bicarbonate's as rare as gold now, so it doesn't matter, but you shouldn't use it if bicarb unless your pH is less than 7.15. Use DVT prophylaxis. They recommend low molecular weight heparin. And you can use mechanical with it, and if you can't use heparin, you can use mechanical devices. Give stress ulcer protection. PPIs are just good H2 antagonists. They say don't use it if people aren't at risk. Nutrition. Don't use parenteral feedings if you can feed them by gut. Do not provide parenteral if you can't feed them right away, but give them glucose. Advance your enteral feedings as fast as tolerated. Use early feedings as soon as possible. Use trophic, which means you can drip little feedings in if they're having difficulty tolerating it. Don't use omega-3s. They don't suggest it. And do not even check gastric residuals. But if they're at risk, this is for non-surgical. We tend to get calls every night. Well, we had 300 and just keep feeding. And then you should set goals, okay, set limits for your patients. So that's what the Surviving Sepsis Campaign does. But my patients, they're never included, okay? They take these patients and they are never included. It kills our patients. That's what kills our patients. So, and we're different. Why? We lose the skin. You lose the barrier. So the bacteria are there all the time. We have the most severe response to injury there is. There is a hypermetabolic response that is turned on that lasts for up to years after the injury. So the engine's revved up. So when the engine's revved up, the temperature's already set higher at 38.5. So you can't use 38.0 for silent fever because they had a fever every day then. And we're stuck with them for a long time. You know, they say pull the lines out as fast as you can. Well, we have people in the hospital for over a year sometimes with a central line. Well, good luck trying to put a peripheral in through a burned hand and have that last for more than a day. So we have lines in long time, and so we are the sepsis kings. So this is like, just a picture. You get trauma pretty quick. Ours go on for a long time. So we tried to make an effort, and we did actually publish it in 2007, the American Burn Association Consensus Conference to define sepsis, infection, and burns. And what we defined is that SIRS occurs in all burns greater than 20%. It occurs, just forget it, it's automatic. It's always there. They're hypermetabolic. So we had to reset the definitions for burns. Let's talk about that. So here's our definitions, okay? It's a sepsis, a change in burn patient that triggers the concern for infection. So instead of 38, we say 39. We actually, in our service, say 39.5. Don't bother because they're 39 every night. Heart rate is always tachycardic because there's catecholamine release all the time. So heart rate of 110 should be a trigger. Respiratory rate greater than 25. And we look at thrombocytopenia. That's more sensitive than white counts. Our white counts are up and down all the time. We look at it, but it's more important if your platelet count drops. And hyperglycemia is another indicator for sepsis or insulin resistance. Feeding intolerance, another definition. And in addition to all those, you have to have something that's infected. Look at a wound, a line, or whatever. So we had actually dropped severe sepsis a long time, and we looked at septic shock. Our septic shock definitions are basically the same. But over the last 10 years, we've had a lot of people say, we have a better definition than you. And I agree, we need to look at it. We're going to need to update it, and that will be our goal. So we need to have a better definition. We need to have a Surviving Sepsis Campaign for burns. So we've submitted a grant to the Department of Defense to do this, to have Surviving Sepsis After Burns campaign. Hopefully someday we'll do this, and we need to have our own bundles. So what is early definition? Because our patients are different. They don't come in with sepsis. They develop it 3 weeks, 6 weeks, 12 weeks. All of a sudden, boom, they get sick. But you need to be just as aggressive in treating them. They come back, they have sepsis multiple times. So what should be the trigger? We don't know yet. Should it be a temperature of 39, 39.5, confusion, pneumonia? there's lots of new labs out there that we can look at. What should we use for that? What's the role of surveillance cultures? We have the most resistant stuff. Right now in the burn unit, we have Acinetobacter, we have Klebsiella resistant to everything, we have Stenotrophomonas, we have some things I've never heard of before, we have fungus. And they may have fungus today, they might have Klebsiella tomorrow, and it's always there. So what should be our bundles? We need to figure that out. What's broad-spectrum antibiotics should we cover? We got to cover the gram-positives and gram-negatives. Should we cover the Stenotrophomonas that's only sensitive to Bactrim? Maybe. When should we change it? When should we stop it? What should we use? Should we use norepinephrine, vasopressin? We need to figure that out. Fortunately, there's not a lot of literature on it. So we need to know when to stop. And how do we look at whether we can improve the outcomes of our patients? So we send the grant. We'll try to do it just like Surviving Sepsis Campaign. I haven't heard from them yet. Someday they'll let me know. And we hope to develop the goal and maybe make this a worldwide effort for the future. So I finished with a couple of quotes. I like this one. Nature is the best doctor. She cures 3 out of 4 illnesses, and she never speaks ill of her colleagues. So Louis Pasteur was a good guy. And then Einstein, we can't solve problems by using the same kind of thinking we used when we created them. So, all right, thank you very much.
Really excellent. Great. And I would actually say, if you wouldn't mind sharing, that I think a lot of that, particularly the summary of the surviving sepsis stuff, if we could get that to all of our residents.
The paper is out there. It's very easy to get. So, yeah, but you can have my slides, yeah.
Sometimes the summary, people like the
bundles.
A few graphics would help. But it's really great.
It's really a good summary of critical care. So it's Jerry.
Yeah, thanks for the update, David. It was great. Can you talk a little bit about volume assessment now that PA catheters have lost favor and people don't know how to put in a central line and don't know that you can actually measure pressure with a CVP? Is it just a guess? Use flow track? What do you do in the burn unit for volume assessment?
Well, we do use flow track. We use the SVV. But they're not very accurate. I mean, it's kind of funny. We've gone back to leg lift as the best indicator, which cracks me up. So those are tricks we did when we were in the ICU. But you can use ultrasound, look at the vena cava collapse. A lot of times what we do is just do a fluid challenge, and a lot of it's a guess. CVP, many papers show CVP is very inaccurate. I still will use the PA catheter because it does help you answer a few questions if you're not sure if it's their volume overloaded or their SVR is low, so it can help you. So I think the idea that it kills patients is ridiculous. But it's just like any tool. It may answer a question, wow, the resistance is really high, maybe something's wrong, or maybe, usually we don't do it because I know for our patients, their cardiac output's 20, their systemic vascular resistance is 180, so they're septic basically a lot of the time. But yeah, I think we do use the flow track. We do look at the SVV. We do fluid challenges. We look at the CVP a little bit. But there is really no good answer other than those tests. I mean, we know there's problems with everything. But, it is, people shouldn't rely on one test to tell you anything. It's just a subtle combination of things. Where the platelets went from 300,000 to 150,000, the white count's now to 30,000. They're making no urine, so those are kind of things like, wow, we need to jump on this and give them volume.
Is it still in this guidelines, wasn't the last one, that if you're unsure of your fluid status and you're not responsive to vasopressors, that besides the steroids, that would be a time to consider using a PA catheter in that circumstance?
Well, they don't say that in this one, but I think it's still an option because, PA catheter giving you first the studies that show to optimize cardiac output, oxygen delivery, all that stuff haven't really worked, but it does give you answers. And they do recommend the CVP with the oxygen saturation. So if you get improvement, instead of the mixed venous, just use a central line. It's not as accurate as mixed venous, but they do help you with a lot of decisions. If you can get SVO2, it's down, and you can raise that up by giving fluids, it tells you an answer that you did something right. Yeah.
I really enjoy your talk, Dave. This might sound really mundane, but it's somebody like yourself that manages people that need central lines over a long period of time. Do you have a strategy, like everybody says you have to change the line every week, but if you know you're going to have somebody with central line for a long time, do you have a routine change? Do you change over wire? What's your strategy?
Well, we do 6 days we put a wire change, and 6 days after that we new stick. And then when someone who's been there for a long time, we may extend that out, because it gets to the point where there are no femorals left anymore because they're all clotted off. And we actually got to a kid that we had, 3-year-old. He had no great veins left, and we just snuck through with one line. We left forever. We also, if there's a high fever, all of a sudden, boom, they got a high fever, we change the line. So we look for it, but we do have a regular scheduled line change. We just had a 90%er go home. He had a line for 7 months, and it gets pretty hard. And then we start leaving them in longer. I think the key is that we round every day and we look for the subtle signs. You have to keep on top and look for subtle signs of sepsis in our patients.
Your whole team rounds together.
Yeah, during the week we round, all of us round every day, because we take every third call every night, pretty much, and it's hard to know what's going on. Right now we only have like 45 patients on service, so it's and the idea that big burns have gone away is, I don't know, we have 3 people over 80% burns right now, a bunch of 60%ers, and it's gone crazy. But yeah, paying attention to subtle changes is what really involves. Great.
Great talk, Dave. I wonder if you might comment on subsets, like you treat the elderly different, because you may have different transfusion thresholds, they may have different manifestations of sepsis, mental status. I mean, it's nice to have guidelines, but what about elderly patients?
We don't do too much different for the extremes of ages. We do babies and adults. They have similar drops in platelet count, increased fluid requirements, air death kind of pictures. I can tell you that you got more room for wiggle in the little kids and the young people compared to adults. An adult, well, we do the LD50. A size burn that gives you 50% mortality. If you're 12 years old, it's about 85%. An 80-year-old is about 8%. So one little fall off the track on an elderly person and maybe they're dead. Where you got some room, you make a mistake on a 12-year-old, they can get it back on track. The sepsis signs are a little bit easier. The problem with the elderly is that they go into renal failure faster. So we kind of keep an eye and try to make sure they get adequate fluids. They get respiratory failure, the cardiac function isn't as good, the reserves are not as good. Similar philosophies, we don't have different strategies per se.
So in our service, we may have a different threshold for transfusion.
Yeah. Well, we haven't done that, although sometimes if they've had myocardial ischemia, we'll probably stretch it a little bit more, keep them up a little higher, but most of the time we don't.
Well, I just want to thank you again for a great ground round and more even the great team that you've developed that really focuses both on the basic science, the clinical science, and brings all that to bear in the care for your patients and the excellent clinical work that you do. It's really a quintessential example of a great academic division. So thank you for your leadership and role modeling for the rest of us.
Thank you.